So as I said, the treatment itself lies in the word variceal. You should give vasoconstrictor therapy, antibiotics to avoid any aspiration pneumonias, resuscitation of all patients as we did into any kind of upper gastrointestinal bleed. The ICU level care has to be of the topmost without forgetting the basics of intensive care, and always take into consideration the airway, breathing and the circulation. The planning of endoscopy and the timing of endoscopy has to be planned after proper optimization. Of course, rescue therapies like which I'll cover up in the due course of talk, and beta blockers should be used into these patients. And remember, if you have a suspected variceal bleed, as I said, resuscitation, airway, breathing, circulation, look for any coagulation abnormalities, monitor the blood counts, the CBC, the sugar levels, look for any evidence of liver disease, do a sonography to find out any element of ascites or a coarse echo texture or splenomegaly which is seen, and then plan an emergency endoscopy after proper optimization. And if there are esophageal varices, if there is an uncontrolled amount of bleeding, you can consider to do either with the help of a sclerotherapy or epinephrine injections or sometimes banding. And in case if the bleeding continues, you should consider a surgical therapy or a intrahepatic pulmonary stenting and a surgical therapy. And the vasoconstrictor therapy is the medical line of management. It reduces the splanchnic blood flow. You commonly use is terlipressin. You should give it at 2 milligrams as intravenous bolus, and then followed by 1 milligram, which can be given every 8 hourly. And vasopressin or nitroglycerin also have been tried, or the standard dose of using octreotide or somatostatin analogs as 50 micrograms to be given as a bolus, and then continue as 50 micrograms per hour as an infusion for the next 3 days to 5 days. Of course, do not forget to optimize the patient, and do not forget to look after the coagulation parameters, and exactly try to determine the exact time when a surgical endoscopy is going to be required. So whenever you have got a suspected bleed, endoscopy is one of the key. Try to optimize the patient with medical therapy along with proton pump inhibitors, fluid optimization, bloods also to be given, band ligation or sclerotherapy, continue octreotide therapy. If there is a chances of rebleed or failure to control, consider to use of tips or surgery. Antibiotics, as I said, prophylactic are usually given into this subset of patients because it significantly reduces the chances of rebleed, reduces the incidences of bacterial infections, because these patients may also have microaspirates or may have aspirated the blood into the lungs, and that can precipitate hypoxia. And as I said, the patient will not die because of the bleeding. It will die mainly because of the complications of bleeding like multiple organ failure or aspiration pneumonia or cardiac dysfunction. And the common antibiotic what we use to cover the chest is either with the help of ceftriaxone or with the help of piperacillin tazobactam, which is there. Resuscitation is the hallmark. Try to optimize the fluids with the help of a CVP or with the help of ultrasound guided to see that the IVC is not collapsing. Take into consideration the cardiac output of the patient. Look for cold clammy extremities are getting warm. See that the urine output is nice and clear. See that the urine output is maintained. The hematocrit and the blood levels is also maintained depending upon the early goal directed therapy. And then planning up of the endoscopy should be formed after proper optimization and as fast as possible to ensure the exact source of bleeding. If the patient's airway has been really needed to be protected, of course, do not hesitate to intubate the patients, and then band ligation should be considered into these patients with large amount of varices or sometimes local injections with the help of epinephrine. Alternative rescue therapies, as I said, transjugular intrahepatic portosystemic shunt therapy or early placement of the shunt within 72 hours is associated with improved survival. But mind you, these are rescue therapies in case if the banding or in case if the medical management or sclerotherapy fails, and the preferred treatment of gastroesophageal bleed is most important. You should rule out a splenic vein thrombosis as the first important part. TIPS is also one of the treatment to be considered. Of course, it requires an expertise. It's a costly mode of therapy, and it should be considered only in those patients where there's refractory amount of bleed or surgical therapy or the age-old sense taken Blackmore tube. It is quite effective for immediate and temporary control, and it will also definitely exact placement is required. Expertise is required. When and how to place it is very, very important because it has got a high complication rate of aspirations or migration, or sometimes it can also give rise to perforations of the esophagus, and sometimes it is used as a bridge until TIPS is being considered. And airway protection is very, very important whenever a sense taken Blackmore tube is being considered. Or you also got a self-expanding metal stent, which are specially designed metal stents which are removable and does not require any airway protection. Beta blockers, of course, reduce the portal pressure and should be considered with the help of the cardiac output, and depending upon the echocardiography and the tachycardia and the blood pressure of the patient, propranolol should be used. Of course, monitor the pulse of these patients.